So good afternoon, everyone, from everywhere you're receiving us from. My name is Elizabeth Mugi, a nurse working at KNH Nursing Standards Department, where we organize a nursing series. And today, being on a Thursday, we are privileged to have a very beautiful presentation today from our individuals working at KNH. Now, this is for a very first time that we are having a very important topic that is a nurse-led intervention. It's a nurse-led intervention geared toward enhancing quality of intrapartum care through implementation of the World Health Organization Labor Care Guide. This is the first time we're having such a nice presentation. We have our seniors who will be taking us through. We all know them. We have Jackson Otondo will introduce himself as he will be doing his presentation, and also Benson Nyankuro. This is a very nice presentation because you are saying it's an intervention, it's an implementation science. They are coming up in with the intervention. They want to implement something in KNH. And the good news is that they have already implemented it in KNH and it's rolling. And just from behind the curtain, I've understood that for the last 2 years, it has been working. So we'll have our first presenter who will take us through intrapartum care for a positive childbirth experience. And then for the institutions who are on board and they have not implemented this guide, don't worry, because our next presenter, who is Benson, will take us through the strategies that you need to implement for you to implement the new labor guide. Such an implementation science or such a topic is very important because with an intervention, they are changing their practice. Therefore, they will lead to an improved patient outcome, that is both maternal outcomes and newborn outcomes. Then they're also going to enhance the customer satisfaction and of course reduce the average length of stay for our patients. And at the end of the day, we'll have a reduced maternal mortality. So it will be a very interactive session. We are having a good number. Thank you for everyone who has joined. So if we have any question, let's interact with the chat box. Ask as many questions as you can. And when you feel points are coming up clearly, then just give them a thumbs up just to keep them well encouraged. So to our first presenter, Jackson, please take the podium and take us through the first presentation and maybe introduce yourself to members. Welcome, Jackson.
Thank you very much, Elizabeth Mugi, and thank you, KNH Standards, for this particular opportunity that we are able to interact with our colleagues as we make this presentation on enhancing quality of intrapartum care through implementation of the new labor care guide. My name is Jackson Otonda. I am a midwife working at Kenyatta National Hospital, and it's a privilege to take you through this session. Welcome, everyone. So the basic objectives of this presentation, one is to introduce the key components and rationale of the new WHO care guide. Also to demonstrate application in clinical settings, that is monitoring, respectful care, and also decision-making. Our third objective is to highlight supportive elements for evidence-based practice in intrapartum care. And also we want to encourage the adoption of human-centered approach to labor management. So why labor care guides in monitoring of intrapartum care or in improvement of intrapartum management? You realize that 1/3 of maternal death and almost half of stillbirth occur during labor or during intrapartum care. That is approximately 835 women are lost during intrapartum care management. And 45% of these, 45% actually are related to childbirth. You realize also that 84% of women that we are losing basically occur in low and lower income countries. That is approximately, we lose 3 mothers out of 4 in the sub-Saharan Africa and Southern Asia. Traditionally, partograph lacks the sensitivity to individual labor variations. That is what is currently being used in most of our facilities, with the exceptions of Kenyatta National Hospital. We are still using the the traditional pantograph. Labor care guide is based on contemporary evidence to ensure safety and personalized care of women during labor. Updated to address over medication and also improve clinical relevance. We've, according to the research that was done by the WHO, that is between 2018 to 2020, before the release of the new labor care guide, it was noted that a lot of over-medication or medication that sometimes are not necessary during management of intrapartum care are in place and sometimes are clinically not relevant. And the WHO would really want us to allow the natural process of labor to occur or to take place. Labor care guide also promotes respectful care and also avoidance of these unnecessary interventions. Why quality intrapartum care matters? Why do we say that we want to improve quality intrapartum care? Like I mentioned, globally, 830 women die daily from preventable childbirth process. 45% of maternal deaths occur during labor or 24 hours after delivery. In Kenya, intrapartum care is critical for maternal and perinatal outcomes. And that is why we say safety equals to, quality equals to safety, dignity, respect, and timely interventions. So this is the guide overview. A labor care guide is initiated during active phase of labor. And according to World Health Organization, the definition of active phase of labor changed from the traditional 4 centimeters cervical dilatation to current 5 centimeters and above. Certain institutions practice 6 centimeters and above, but the recommended WHO active phase of labor starts from 5 centimeters cervical dilatation and above. Compares labor events against reference thresholds rather than fixed timelines. If you realize that traditional pantograph, we have a fixed action line, which is basically based on cervical dilatation, as opposed to the current labor care guide, where we are going to see the threshold vis-a-vis the assessments that we are doing. So there are a number of assessments that we'll be doing against the threshold for each, so that we are not just fixed on 1 hour, 1 centimeter dilatation criteria. So we are going to see in the subsequent slides how these thresholds ranges. The WHO or LCG, like we commonly call it, integrates clinical observations with decision-making prompts. So we also have a place for shared decision-making, where after doing an assessment, we are going to discuss together with the consultant, discuss together with the mother, so that we make a decision that is teamly. It also applies to all delivery settings, be it in our dispensaries, be it in our tertiary level facilities. The LCG also reinforces documentation, continuous assessment, and also finalized action. So in the subsequent slides, we'll see how this goes. So the structure of the labor care guide, it has 7 sections. Section 1, which usually refers to as identifying section, where we just get the details of the mother in active phase of labor, admission details, parity, the status of the membranes, labor onset, and if at all there are any risk factors. And if you notice, we've captured risk factors here in the identifying information, which is not there in the traditional pantograph, and also the status of the membranes, which is not captured in the identifying information in the traditional pantograph. A second section which is very important. That is the supportive care bit, which captures companionship, mobility, pain relief, and also oral fluids. These are not captured in the traditional pathograph. And then third section, care of the baby, where we monitor the fetal heart rate, amniotic fluid, the position of the baby, whether we have caputs or molding. And then our fourth section is maternal well-being, of course, the observations of the mother, pulse, blood pressure, temperature, a urine analysis, and of course, we'll see the frequencies at which we monitor these observations. And then section 5, we have the labor progress, where we look at the cervical dilatation, the descent of the fetus, and also the strength of the contractions. And then we have the medication bit. If at all there are any medications that are being given during the intrapartum period, any IV fluids, and whether we've augmented labor at this point. So the use of uterotonics is also captured. And then the last very important bit is the bit of shared decision making, where we have the patient provider dialogue with the patient, so that as we make decisions in cooperation with the patients, also understanding of what we want to do or what we intend to do. So this is basically how the new WHO looks like. Section 1, as indicated, is the identifying information. Section 2, supportive bit, as you can see. And then we also have the baby and mother monitoring. We have labor progress, section 5. We have medication bit, section 6. And then section 7, we have shared decision making. As you can see, we have an alert column. As you go vertically downwards, you see the thresholds that we are talking about on the alert section, where you'll see under companionship, we have a no, pain relief, we have N, oral, we have N, and posture, we have SP. So those are the alerts that we are talking about. Try if we are able to. So this is the alert section we are referring to as we come down for. This is the alert section that we are referring to. Is this section here. So in the traditional pathograph, we only have cervical dilatation that is being checked against time. For example, if we have, if a mother is at 6 centimeters at 2, then we expect her to be 7 centimeters at 3. However, when you come to the LCG, you'll find that you are being given the alerts here that you are to check against. For example, companion, during supportive care, or as you offer supportive care, every mother is supposed to have a companion of her choice, whether it is the next of kin, whether it is the mother-in-law, any companion that the mother wish to have, then it's supposed to be allowed to have a companion. And then when you come to pain relief, we are supposed to offer pain reliefs, whether they are pharmacological or non-pharmacological. So if you offer pain relief, then in that chart, in the next space, you're supposed to indicate with the Y for yes, and then also companion, if the companion is available, you indicate with the Y for yes. If the mother doesn't accept or doesn't want to have a companion during labor, then you indicate with the D for decline. So all this is checked against the alerts. So where an observation or an assessment matches the alert, then we are supposed to circle it in red. That will mean we are supposed to act on that particular assessment item. When you come to baby care, where we are monitoring the fetal heart rate, we've also included the fetal heart rate deceleration. We've included amniotic fluid. We've included fetal position. We included caput and molding. And if you look at our alerts under baseline, any fetal heart rate that is below 110 is an alert, and any that is above 160 that is also an alert. That is tachycardia or bradycardia we're referring to. Then we have fetal heart rate deceleration. There is an L that is indicated for the alert. That will mean a late deceleration. As you all know, we can have either an early deceleration, a late deceleration, or a variable deceleration. So maybe in our next, if we get an opportunity, we'll go in depth to look at these types of deceleration. Amniotic fluid, you realize we have first meconium stain liqua grade 1, grade 2, grade 3. So when we have a grade of 3 or an amniotic fluid that is blood stained, those are our alerts, and we should act on them. When we have a fetal position that is either posterior or transverse, in our assessment, those are our alerts, and we should keep checking the position maybe 4 hourly, depending on the cervical dilatation of the mother. And then also caput of 3 pluses, molding of 3 pluses, those are alerts. So there are instances where when you have a mother with the meconium stain liqua grade 3, you will not wish to continue with that delivery, especially in early active phases, and you'd want to hasten the delivery. So sometimes delivering the mother via cesarean section would actually improve the outcome of the fetus. Also, when you come to the care of the mother, we have the observations, and we've been given the ranges within which are normal, and without which or over and below are abnormal. For example, pulse of below 60, pulse of above 120, those are our alerts. Of course, diastolic pressure of more than 90, those are our alerts. And we've also included now urine analysis, where we are looking at the proteins present in urine and also acetones present in urine. You all know that when proteins are present, we could be dealing with the pre-eclampsia or eclampsia. And whenever we are having acetones, we could be dealing with diabetic ketoacidosis, or sometimes we could be dealing with dehydration of the mother. That is why mostly you look, when you get into the supportive care bit, we have oral fluids that is being offered to the mother during intrapartum phase. And then under labor progress, we have the strength of the nature of contractions. Here we've been given alerts as below 2 and above 5. Where we have below 2 and the mother is in advanced active phase, then you have reasons to augment labor. And where we have frequencies of more than 5 in 10 minutes, and the mother is probably in augmentation, then we can basically stop augmentation of labor. In the traditional pathograph, you remember there is shading or lines for contractions or the nature of contractions. While in the new care guides, we usually write the actual number of contraction and how long each contraction takes. There is no shading. If we have 3 contractions in 10 minutes, then we just write averagely or approximately how many seconds does each contraction take. So if it is 3 lasting 40 seconds, you just write 3 and 40 on the duration, or 3 or 20 on the duration. Remember, even the duration has alerts of 40 seconds and above 40 and below 20 seconds. Same applies to cervical dilatation, where we have, we say the care guide starts from 5 centimeters and above. And if you look at our alerts, you find that a mother can take not more than 6 hours when she is 5 centimeters, 6 centimeters not more than 5, 7 not more than 3, 8 not more than 2.5, and under 9, not more than 2 hours. So, like we said, in the traditional pantograph, you realize we are moving at a standard threshold of 1 centimeter per hour. When you come to the near labor care guide, this guide is trying to individualize intrapartum care, where it was noted that not all women can have a standard rate of cervical dilatation. One would dilate at 1 centimeter per hour, but the other one will take even 2 hours before progressing to the next centimeter. So some would go even 3-4 hours, and they're still in active phase of labor, same centimeter, and the outcome is still as good as the mother who had 1 centimeter per hour dilatation. So these are the changes that has informed the revision of intrapartum care. Where we don't have the threshold is descent, simply because the descent of the baby sometimes is subjected to the strength of the contractions that sometimes will make the baby descend. And then this section 6, we've talked about medications that are being used. And this assessment, we do it every hour. There is no alerts or threshold. We want to minimize interventions as much as we can during the intrapartum phase. So if the labor progress is okay, the contractions are within the thresholds, then there is no need for interventions. We don't have to give oxytocin, you don't have to give Buscopan, you don't have to give IV fluids, you just give the oral fluids that are within the supportive care. And then we come to the bit of shared decision making, where after doing all our assessment, then we are able to note our overall impression or our overall assessment. Like we will say the mother is in active phase of labor, that is in the initial assessment, and then we give a plan. So our plan will depend on how our assessments were vis-a-vis the alerts that have been indicated for us. So we already have the alerts given for us. You only record your assessments, then you counter check with the alerts. So those that would match the alerts are the ones that we identify action points and we come and write on the plan. This plan is shared decision. We have to inform the mother after every assessment. This is where we are, and this is what we have noted, and this is what we intend to do. In some instances, remember, the mother has the right to decline or has the right to go with which one she feels comfortable with. Of course, you'll have to explain the merits and demerits of this. So clinical applications, remember we said, first of all, you conduct your assessment, then you record, then you check vis-a-vis the alert thresholds that have been given. Then we are now going to plan on the care that is we looked at the shared decision making level. So assess regular evaluation of woman and fetus based on 7 LCG sections, record observations, check, that is compare value with the alert threshold to identify deviations from normal, then make a plan, then support timely recognition of complication. The beauty of this is whenever you do an assessment and you find it meeting the alert threshold, then as we plan, we intervene immediately. So there is timely recognition of complications and interventions. So it also reinforces teamwork among maternity staffs and reduces unnecessary interventions. Because you remember, when we are making decisions, we are sharing, either the consultant, the team leader is available, or sometimes a senior midwife is also available, that we are able to make decisions. So this is how it looks, the identifying information like we have explained. I was trying to come up with something that is practical that we can also see. For example, this is a pseudo patient, Mary Jane Williams, parity, onset of labor. Onset of labor, there are only 2 two indicators that we can write here. It is either spontaneous or whether we had induced the mother. So if the mother was induced, then labor type of labor onset becomes induced. If it is spontaneous, the mother came in labor, natural, then you just write spontaneous. Then date of active labor and status of membranes. When did the membranes rupture? Remember, in the traditional photograph, we write how many hours ago has passed since the membranes ruptured. But here you write the time and the exact date. And then we also have a bit for the risk factors. These risk factors could either be medical, obstetrical, psychological risk factors. For example, say a mother has chronic hypertension, has diabetes. We have also multiple pregnancies. We also have, say, meconium stent like, but those are risk factors. So you have to indicate them there. Then the second section, we say the supportive care bit. This is how it appears. And as you see, in our pseudo patient, on admission, on our assessment, the patient did not have a companion and the patient was not having a pain relief. And there were oral fluids that patient was able to take, and the patient was in mobile position, that is MO for mobile. I have a slide where I show you the initials and what their meaning is. So when you offer companion, then in your next assessment, it is Y for yes, the patient now has a companion. Same, the patient has been offered a pain relief. So in our next assessment, the patient has pain relief. And also, oral fluids continues. The patient is supposed to be on oral sips during intrapartum phase. Then, unfortunately, during as we were still monitoring labor, then the patient turned into spine position. We all know what happens when a mother lies in supine. What happens to the fetus? That is why we encourage a mobile position, which also helps in descent and also help in placental perfusion. So when the mother goes into SP, you remember it. You see, it is coinciding with the alert. So you just circle it in red. That will mean it requires an intervention. You don't just circle and leave, you circle and intervene. Section 3, we have baby, care of the baby, which we include here the fetal baseline. You can see for Mary Jane, how the fetal heart rates were within the normal threshold, and also baseline as well. But when you come to the position, you find the baby is still in posterior position. The position here refers to the position of the occiput. When you do a vaginal examination, where do you feel the occiput? Of course, there is nothing much you can do apart from circling it in red. We just want to know that in our next vaginal examination, is the position still posterior? If it is posterior, then probably we getting to understand that we could be dealing with persistent occipital posterior position. That is the beauty of getting thresholds for every assessment. So you can see we have fetal heart rate, fetal deceleration, amniotic fluid, fetal position, caput, and molding. And then when you come to section 4, very obvious and very critical in monitoring of the mother. As we monitor the baby, we don't forget about the mother. So we also have observations for the mother and their thresholds. And section 5, very important, the labor progress, where we are looking at contractions and their strength. As you can see, we said we are not shading like in the traditional photograph. We have the number of contractions in every 10 minutes for 30 minutes. Like here we have 3 lasting 40 seconds, 3 lasting 44 seconds. So you write how many contractions are we having in 10 minutes, the actual number. Remember in the traditional photograph, shading the number of boxes. Whether there are 3, we shade 3 boxes, but here we write the number. If they are within the normal threshold, then we just leave it like that. We continue with monitoring of labor. Cervical dilatation with an X, and then also descent with a circle. Section of shared decision making and medication. As you can see, we are trying to minimize intervention as much as possible. If you look at our alerts, most of our alerts are in the supportive care area. That would require whether we offer pain relief or we just give a companion, we offer a companion, we change positions. So when you come to the medication bit, for example, on pain relief, sometimes you just offer non-pharmacological medication. If you offer pharmacological medications, you can give tramadol, you can give paracetamol. Those are approved by the WHO as medications that we can give to relieve pain during intrapartum care, or sometimes pethidine. So this is how eventually your labor care guide will come out during monitoring. So supportive care bit, we are doing assessments every hour. Baby care, fetal heart rate, we are doing every 30 minutes. Amniotic fluid, fetal position, caput, molding, we are doing every 4 hours, like as we are doing vaginal examination every 4 hours. Mother or human care, we are doing every 4 hours, that is the vital signs. Contractions, as usual, every 30 minutes, we are doing assessing for contractions. Labor progress, every 4 hours, like we are doing the vaginal examination. Medication and shared decision making, we're doing every hour. So that is how eventually our labor care guide will look at. The beauty of WHO labor care guide is medication and shared decision making bit, so that we have timely intervention and minimize unnecessary medication, unnecessary cesarean section. So the new labor care guide also promotes respectful maternity care in the sense that women are offered companionship of their choices, and then also provide communication respectfully and share care plan. After every assessment, we are able to communicate with the mother, tell the mother what the findings are, and what we anticipate, and our plan of action, and we also allow the mother to give her input. In this way, then we enhance the communication between the mother of the woman and the healthcare provider. Also, women supported to drink, eat, and also move freely unless contraindicated during intrapartum care. Care includes respectful personal values, privacy, and also autonomy. So we want to also respect the values of the woman. If they tell you this is not what they would want, this is what they would want, in as much as sometimes you explain to the mother those that will be beneficial to her, they also have their values that sometimes we must not impose our values on them. And also it encourages positive experience for future use of maternity services in case they appear pregnant again in their next. So how does this impact? How does labor care guide impact on maternal outcomes? One, it improves childbirth experience and perceived care quality. It also lowers the fear of childbirth post-intervention, as you always reassure the mother, you always communicate with the mother. So at all times, every assessment, you are always at par with the mother. She's always involved. Increased maternal involvement in decision-making promotes trust and comfort within with the care providers. When they have their companions, you also involve them in the care of the mother. They are also kept up to date of what is happening and the anticipations. It It also contributes to better emotional and psychological recovery. Those are impact on maternal outcomes. And then on the neonatal outcome, we are able to detect early fetal distress through routine fetal heart monitoring, promote safe monitoring of amniotic fluid, molding, and also caput. It also encourages timely action to prevent adverse outcomes. No significant change in APGAR score or exclusive breastfeeding. It remains, it doesn't change anything to do with breastfeeding, as we encourage mothers to initiate breastfeeding within the first hour of delivery. And it also supports safer clinical judgment regarding intervention. Wherever there are interventions that will require medical interventions, there is timely interventions. I would now maybe leave the next session for my co-presenter. As you realize, in Kenyatta, we've started the implementation of the new labor care guide, and we ended our second phase, that is the second year running. There are a number of strategies that we did put in place to see whether the new tool is feasible, whether it's acceptable by our midwives, and whether it is user-friendly, and does it meet the anticipated outcome? Does it minimize interventions? So we just want to see, or we just want to get it from my co-presenters, how we had rolled out the implementations. What are the steps that we took when we were implementing the labor care guide? Thank you.
Wow. Congratulations, Jackson. I'm sure as you're doing your presentation, you'd appreciate the feedback we are getting from participants. So much thumbs up coming, congratulations message. And I'm also sure that you felt proud presenting it. It's like your own document with like your own work. So congratulations. We have more than 600 midwives on board and with so many questions. And I'm sure as we finish with the second presenter, you'll be able to respond to these questions. So now to the next presenter, Benson, please introduce yourself and take us through the strategies now that some of us have not implemented in our hospitals. So you're most welcome.
Thank you very much, Mogi, and thank you, Tonda, for that wonderful presentation. So before I proceed to do my presentation, I want to point out that the WHO Care Guide was largely founded on the principles of respectful maternity care. And so if you, the most important take-home message we want you to pick, should you not get anything today, just go knowing that it was about respectful maternity care, where now we have a paradigm shift to involve mothers in their care. Gone are the days when we used to examine women or patients, and then we don't give them feedback, or even the way the traditional practice has been in healthcare spaces, where so a doctor would see you, and then they would script a prescription and let you go without telling you what they are treating you for. And they like, so we want, most importantly, our take-home message as we, from this presentation is that we try and involve mothers in their care, so that if you have a finding, you tell them this is where we are. It makes the care easier. It makes the care bearable, even for the mother. They go through the pain of labor much more comfortably than when you do not involve them. So now we are looking at strategies for implementation of this care guide. It's a new tool. Anything new, every time you're implementing any change, it's never easy. So change is not an easy thing to implement. It's difficult. It would have teething problems. But in our space, we are grateful that we have taken off over the last 2 years. We've been using this new tool. So now, some of the strategies we are looking at include stakeholder engagement. Now we have to involve all our obstetricians, the midwives, nurses, administrators, and the patients, as we've just pointed out, that this care guide was founded on the tenets of respectful maternity care. So conducting of sensitization meetings, we have had a good number. This is the first rollout that we are sharing with midwives and other healthcare workers across the country. So, and we hope that going forward, we are able to share some more of this and engage further with peripheral facilities, other surrounding facilities, and see how this works. We do have an implementation task force in our setup that does regular clinical audits to check how are we doing it. And so for our own staff, we are doing hands-on training in the work setup. So the other thing we are looking at is capacity building and training. We think that if we train healthcare providers on all the components, at least this is a startup for sensitizing everybody that there is something like this, is a labor care guide looking like this. And so when we start now the training, we would, this is something that is for discussion. We let it for administrators to use their discretion and consider what works in their little spaces, their facilities, their setups, their institutions, their hospitals. Now, we also consider using clinical drills and simulations for their practice. This, for us, we are working on, and we hope we can encourage all of us to do that. Then the emphasis, and which is what I've already pointed earlier, is for respectful maternity care. One of the most important paradigm shifts we wish to see from this is that thing of respectful maternity care. Traditionally, as you know, our practice has not been a very good engagement with our clients, where you would examine, you'll find the findings, but then keep to yourself. It is keep the client as the most important stakeholder and have the courtesy of telling them, when I took your blood pressure, this is what I found, and this is okay. It is not enough for you to take my blood pressure and you know it, and you move on to give me drugs without telling me why and what's going on. So it's important that you tell me this and that. So involve the mothers. Now, the next one is to try and customize this labor care guide to local setups. In our implementation, there are things we have found, we have picked that we think are for modification. So depending on your setup, you'll figure what is there to change. So pick the WHO rolled this out, and so in 2020, so it is for the respectful countries, hospitals and institutions to try and tailor to their own protocols and see how it works for them. If need be, there may be places where it may require this care guide to be translated into local languages if needed. Now, again, trying to integrate this into existing systems, we already know that our work involves a lot of documentation. We have documents like the cardex, fluid charts, etc. Those now, what we know that even in the previous patograph, we had sections for documentation. Thankfully, this LCG, as we have said, has sections, as my co-presenter has already pointed out. We have where you had seen, he was pointing to alerts, where when you circle alerts, there is a section below where you're supposed to indicate then what did you do to that alert. So how do you, what action did you take? For example, if you found your patient is lying in a position that is supine, which is not encouraged, what then did you do? Did you encourage them to adopt a mobile position? Again, so again, ensure for places where and organizations where you have gone online. Most organizations are trying to go paperless, and we are in that space as well. Try to see how that works for you. Monitoring and supervision, like I pointed earlier, we have an implementation task force which does conduct regular audits and gives us feedback as to how we are doing, whether we are filling the components properly, whether the tool is being used appropriately and for every woman. Remember, this labor care guide again on the same principles of respect for maternity care is for every woman. There is a woman who's going to say they want a companion during their labor. There is one who's going to say they decline their companion during their labor. So all that is to be respected depending on the individual woman. And then also use feedback tools to evaluate adherence and address the gaps. Of course, that from the audits will inform us. Then we have quality improvement. Adopt this as also quality improvement thing. You can pick it as in your circles once you implement. Try and see, is it like if we start implementing now by December, how is it? Are we doing better with the monitoring of every woman that we are handling? Then also apply the plan to do study act cycles for continuous improvement. Same thing with the quality improvement. Now, community and patient involvement, we also would like to roll this out in antenatal clinics and try explain to the healthcare workers as well as the mothers. Also, that is where we are supposed to inform them. It is in the antenatal spaces where we're supposed to inform them that they can actually, they are free to come along with partners if they so wish. They can adopt any position during labor and delivery, what works for them. Let us remember that previously, we have always thought that a woman should deliver in a lithotomy position, but now we know that women can deliver even in a squatting position, in a knee chest position, whatever works for every woman. And then again, we wish to promote shared decision making and respect for healthcare. There is this is our emphasis. Where a woman chooses to be with a partner, they can be with a partner. On policy and leadership, our suggestion is advocate for this care guide to be adopted as in our national maternal guidelines, the care, because we think from where we have done so far in the 2 years we've done, we think it's a very wonderful tool. It does improve the very much on the photograph. And then also, it is important that leaders, including administrators, policymakers, that they support this for this to be sustainable. Resource mobilization. So what we need largely is to ensure that we have these tools supplied. If you are in a space where you're using manual files, let the care guides be printed. If you are in a space where you're using you've gone online, that is also possible to be done. Again, we've already talked about training of healthcare providers. So we need resources for that. We will need to do several seminars and symposia to be able to achieve this. Data collection and use. Now, we, of course, from our audits, we are able to pick this. Again, also, we have not worked in a space that is so long. We've not worked for a very long period, but we've worked long enough where we can pick data with this tool and see whether maybe sometimes if we are going to do a retrospective study, again, this is also something to handpick for researchers. Pick where we have implemented this and compare to photographs used previously. Is it making, does it give us better outcomes? These are things that can be looked into. And then also track key indicators and see whether, for example, where we are using this tool and previously where make comparisons like this, where you're comparing the rate of C-sections vis-a-vis normal deliveries. So is it giving us a difference? Is it reducing our index of cesarean sections, or is it increasing from its use? Thank you very much. We can take questions, I believe.
Wow, thank you so much, Benson. Again, also appreciate the lights that were coming as you're doing presentation, they're still coming. So I'm sure you feel proud of yourself. Thank you for articulating this topic in a manner that we are able to understand. Personally, I'm not a midwife, I'm a renal nurse, but I could be able to follow. So we also appreciate that you have brought up the point so clearly as to why the rationale for coming up with this tool is that the traditional photograph lacked sensitivity to individual labor variation, and therefore you're now individualizing patients' care. So straight to the questions, let me take you through the questions. Now, let's start with Mary Murio. She's asking, what are the main problems that come? I'm sure she's asking much of the experience that you have had. The problems that come with the presence of the companion during labor, especially in second stage, and how have you mitigated such a problem? Jackson, would you take us through this one?
Thank you so much, Elizabeth, and thank you, Mary, for your question. Of course, for every new tool, for every new intervention, there are, of course, teething problems. Sometimes our spaces cannot allow us accommodate companionship, like in KNH, the space, and also sometimes the hospital policies in our general ward does not allow us to have companion. So as we assess the companionship in general ward, it remains marked red, and we are actually looking at what happens now that we've continuously marked it red without any intervention on companionship. But when you come to our KNH private wing, where we also use the same tool, its companionships are allowed, and there are private rooms. We also encourage women to deliver in their admission beds. So where we have the mother and the companion where she's admitted, encouraging a delivery there together with the companion, it's worked for us.
Wow. That's a thumb up to our KPCC department. If they're able to conduct delivery at the patient bedside, I think you're making labor process to be as natural as possible. And I think as you have answered, you have also answered Millie's Karina, because she was very curious to understand how you're able to allow companion, especially in our small spaces. But we appreciate, like you have said, as time goes on, as you implement the tools, those are some of the things you are working on.
Yeah, that is why maybe my colleague was talking about if we can align the labor care guide to our setups. Yeah, whether it could allow for certain interventions or it could not allow for such interventions, and what will be the anticipated outcomes.
Wow, yeah, sure. We align the tool to our setups. How about Braxton Onyango from other pushing at supine position? Should we circle position as SP?
Yes, we should circle as SP, that is supine. Remember, we are encouraging the mothers to assume positions that are comfortable for them. The lithotomy position has always been the comfort of the midwife, but not the comfort of the patient. So where patients are comfortable delivering spine, you can encourage them to be in spine, only that sometimes it interferes with circulation, fetal circulation, or blood circulation to the placenta. That is why we want to assume other positions. The mother can lie, but deliver in a left lateral position, can squat, or assume the all fours position, which has been a very much an outstanding position for delivery of mothers.
Sure. So SP will be circled throughout.
Throughout.
All right, thank you. Benson, Teresa is worried. Ireri, she's kindly confirm about the use of tramadol in maternity.
Thank you, Teresa, for that question. For all purposes and intents of the knowledge we have, pharmacological and otherwise, tramadol is a safe drug in pregnancy. We do not have, there's nothing contraindicating it in pregnancy. It's safe to use.
Oh, thank you so much. And now that this is a nurse-led intervention to enhance the outcome of our maternal cases, anonymous attendee is asking, is it within our scope to prescribe or give pain-relieving drugs?
Thank you. It's only that it's anonymous,
Mhm.
but you realize that the only nurses allowed to give a prescription are midwives. I think maybe it's not in the knowledge of most of us, but for example, you're having a mother with postpartum hemorrhage, you are alone. You can't wait for a prescription to come so that you can avert the postpartum hemorrhage. Likewise, in the same situation, we're encouraging our midwives and nurses to be giving pain relief. And we've said this can be pharmacological or non-pharmacological, where we give back rub, we give breathing exercises to these mothers so that they can able to get a bit of relief.
Oh, so it is now within our scope for the midwives, you have said that. Right. And we're still there. Nursing standards, we are champions for documentation nursing process. In the part of in the LC, when you indicate, like, for example, you have given tramadol and then you give a tick. So at what point are we able to know you gave tramadol? Why do you document that?
In the part of companionship, you indicate with a Y, meaning yes, I've given. And then when you come to the medication bit, there is an area for medicines given. You indicate the type of drug, the dosage, and the routes. If I've given IM, it is IM tramadol, 100 milligrams.
Right.
Yes.
That's very good, because from what we had seen, we saw a tick.
Then when you come to section 6,
Okay.
there is a bit for medication where you indicate the medication that you've given.
That's perfect. And just to ask, does a labor care guide replace nursing cadets?
It does not replace the nursing cadets. what we are doing, we're just trying to improve on intrapartum care, but we are not replacing the cardex. What we are trying to move away from is the partograph.
Okay.
It's the partograph, so that we try to allow the natural labor progress to take place.
Wow, that's very clear. Benson, you have something to add on that?
No, it's, I think the question is, from just being on is,
No, yeah, we are good.
are we replacing the photograph? Yes, we are.
Yeah, Josephine is quite worried, though she joined in late.
Exactly.
She's worried. I think they have not moved, her and her institution, they have not moved to the photograph. But I think she has seen the strategies to move.
Yeah.
But clarify to her that you are replacing the card expense.
Not the cardex.
Sorry,
the photograph. Yes, the photograph we are replacing. We think that the components, the assessments done by the WHO was spot on. They have included components that were not captured in the photograph, which is why we are looking to adopt the labor care guide.
Oh, all right. Thank you. Then Victor Ojua is asking, when should oxytocin 10 international unit intramuscularly be administered? Is it immediately after baby born or after delivery of the placenta? And he's also asking, how effective is the administration of the 10 international units oxytocin IM to the mother who is being augmented with oxytocin infusion?
Thank you, Victor. I think we always, in the protocols, we give it within the first minute after delivery of the baby. Initially, we used to give it after the delivery of the anterior shoulder, but we realized that sometimes you could be having an undiagnosed twin. So you give it after complete delivery of the baby before the delivery of the placenta, because it also helps with the delivery of the placenta. How effective is administration of 10 IUIM to a mother who has been augmented? Very effective. It remains one of our strategies in prevention of PPH as part of active management of the stage of labor. Administration of IEM and IU oxytocin is mandatory.
I think that's one area that we have issues, you as midwives, because you can see the response, you give the responses, what happened to, there was a lot of thumbs up, meaning you guys were in agreement.
Yeah.
Wow. Benson, Anonymous is asking, which fetal heart rate range are we using with the latest guideline?
Very well. So our latest guideline in our local setup, in Kenyan setup, is 110 beats per minute to 160 beats per minute. That is the current guideline.
Oh, okay. Anything less than 110 is
Bradycardia.
Yes, anything less than 110 is bradycardia. Anything above 160 is a tachycardia.
you should be concerned there.
Yes.
Anonymous, why are people anonymous? We want to appreciate people with their names. However, Jackson, they're asking a question concerning part 2 of the labor guide.
Okay.
That is supportive part on companionship. With our ward setup, is it possible to have a labor companion for a mother in active phase of labor? Say you have 5 mothers in labor, meaning you'll be having 5 other companions. Will this not affect service provision to the mother and the general care of the client?
Okay, thank you. I think we had talked about it. I totally agree, And these are some of the issues that we are trying to grapple with within our spaces. But there are facilities that have got enough spaces. There are facilities that the ratio of maybe nurse to patient is within the WHO requirements. So that is in the implementation bit, one of the strategies we said we try to align, and also we also try to bring the leadership of the facilities into the pictures we implementing, because without the leadership and also explaining to them why it is necessary to have a companion with regards to respectful maternity care, then we will not be able to achieve any. So we bring the leadership, we also try to align these things to our setups.
Oh, sure. I think you have answered that question, and you have also answered Minimuru, because she's also concerned that the major problem in intrapartum care is the provider-mother ratio. And she's asking, will this new tool lessen the burden? And I think you have addressed that question well. And I've heard you emphasize that we look at the bigger picture, the benefits of using the tool, and then we try to customize it to our local places.
Yeah.
We'll see how we can work on it. Alnada, what can be done to prevent mothers being referred from peripheral facilities to KNH too late, that either the mother or the baby either dies? Mothers ending up in should be ICU, and the baby coming out with severe perinatal asphyxia.
So, thank you very much, Ngondo, for that question. I think we have shared previously. I did present on referral streamlining referral systems, and we continue to give webinar CMEs on strengthening referral systems. The idea about referral, the best answer I could give you is the idea about referral is to optimize care at every level. And then that also is the responsibility of the care provider, whoever they are, at their level to recognize. So you are able to recognize that this is a complicated case. I think it's something that might need a whole other session of presentation to guide us on what to do. So that now we know what to do, so that we keep following our webinars, so that we will repeat some of those presentations to tell how best to refer, how to identify a client who needs referral and early referral, so that we optimize care at every level. Thank you.
Wow, thank you for that. We should be winding up, but Margaret Kariuki is asking, when a mother begins to push, when is it considered an alert? After how long?
Thank you so much. I think, Margaret, you are very keen on the presentation, and from the care guide that I showed, I think you noticed there is a section for monitoring during second stage of labor, which is not in the traditional patograph. So for primary gravidas, we allow second stage of labor can go up to 3 hours, and for multi-gravidas can go up to 2 hours, but this is only when all the parameters are within the normal threshold. Do not allow a primary gravida to go for labor second stage for more than 3 hours just because we want to meet the 3 hours, but kindly look at it vis-a-vis the thresholds that we've been given. So how long is dependent on the thresholds, like the fetal heart rate, is it okay? Are the contractions adequate? Is the mother stable? Is the baby okay? What is the nature of the status of the amniotic fluid?
Wow, thank you. Anonymous is saying that the labor care guide is set to transform maternity care, like Benson said. So he's asking, in your own experience, have you faced challenges with overcrowding, especially in public facilities? Since avoiding unnecessary intervention, that you said you don't have to have them, means longer stay in the labor ward, in addition to the presence of the companion. So I think according to her, she wants to hasten labor with the interventions.
I think we've highlighted that in our setup in the general wing, we are not able to offer companionship, making that bit of companionship to assess a bit tricky on our side. But if we go to our private wing, we are able to access how it impacts on intrapartum care. So where you have spaces where we have few number of mothers in labor, we can try and see if this works for us.
Now, Osborne, so for birth companion, they need to make sure space will allow presence of birth companion, like providing chairs. Also, it is important the identified companion be given an orientation on do's and don'ts. I think that's a good comment. Thank you for that. Like they have said, let's try to tailor make this labor guide to our setup. think most of the questions have been repeated here. Has the LCG been adopted in the national guidelines? Janice Patrick is asking.
Yeah, if you go through the 2022 obstetric guideline, it's part of the pathograph as well. So maybe if we can get directives from the Department of Reproductive Health, of which in some instances they say they've started rolling it out, but I'm not aware of any facility that is currently using labor care guide apart from KNH.
Wow, thank you. Mili Karina, I think this is a bit individualized question because she's asking for induction of labor. What medication is KNH using? But I think this is another presentation all the same. Or if they're around, they can visit our unit. Yes. Hey, and Andelight Nawire, well done. Big up to those dedicated members. Congratulations, Tema.
Thank you.
Yeah. And then Kanamada, that is Braxton Manyango. Kanamada have fetal heart rate of 120 to 159 with late deceleration.
Yeah, remember when we were plotting under baby care, we talked about the ranges between 110 to 160, and we're also looking at deceleration. Before you, on the identifying information, we are looking at the risk factors. So one of the risk factors that can make a mother have a late deceleration, remember late deceleration signifies placental perfusion. So when a mother is anemic, then the placental perfusion could be impaired, and sometimes they could present with late deceleration. So as you make your assessment, you look at which kind of risk factor am I having, which kind of patient am I dealing with, which comorbidities are we dealing with, and that is why we are saying labor care guides individualizes care of a mother. So you can have in instances where you have impaired placental perfusions like anemic mothers.
Wow. Okay. We are seeing most of our colleagues are asking whether you could email them soft copies of this photograph. Is it that it's only KNH that have implemented this tool, or there are also other facilities that are doing the same?
So far, it's only KNH that I know of. But when during the pilot study that was back in 2020, I think St. Mary's was also among, St. Mary's Langata was among the facilities that were chosen to pilot.
Wow.
Yes.
So that's a big up to our midwives in KNH for taking the bull by its own and implementing this tool in Kenya. So others question, a mother come in labor but has poor progress. She's augmented with Sinto, and later she ends up in theater with ruptured uterus. What may have caused the problem?
So now, thank you. That is, she's called physiotherapy. Now, that would be based on the clinical assessment of that patient. What were the findings on examination and laboratory investigations? What is exactly going on? It's not possible to tell directly what could have been the problem. Again, also the assessment of contractions in labor. Do you have hyperstimulation of the uterus? That is why it is important in this tool that we are plotting the number of contractions. There is where the first presenter pointed out that you write in the number of contractions the patient is getting in 10 minutes. Where you have 5 and more contractions, that is hyperstimulation. So if you have that and you add oxytocin, that would be injudicious use of oxytocin. So we should be careful to use, and that is why this care guide is focused more on natural birth and reducing interventions, medical interventions and healthcare worker interventions to allow labor to progress naturally.
Wow, thank you so much. Hey, congratulations to Janice Patrick. He's saying that some of the teaching and referral hospitals have started implementing the labor care guide, like George Yahe. they are,
GTRH.
they are doing it. So congratulations. We are also looking forward to a presentation. You can help us during our nursing series to present, and we also want to hear your experiences from that point.
Thank you so much, Dr. Jill Patrick. Dr. Jill Patrick is one of the leads in RAMCA, Department of Reproductive Health
Wow.
and Child at the Ministry of Health.
Wow. Wow, thank you so much, Doc. We appreciate. Yes, to our midwives, a big congratulations from our senior principal nursing officer in charge of Ops Gynae, Wara Kiptulgo. She's saying very good presentation, Mr. Otonda and Nyankuru. He's very proud of you. And we're also very proud of you to be associated with you.
Thank you.
Bright mind, great presentation. And there are some questions that you have jumped because they are not directly related to our today's presentation. There are many questions people are asking. They want to benchmark with our practice here. So we'll sample some of them because they're asking, like, I don't know what you do, the first line treatment, something of the sort, then you can give us another presentation. So I think those are the many questions we had. We now come to the end of our presentation. And again to our midwives, congratulations for representing your department ably and representing TNH to this an international forum. We look forward. Yes, Jackson.
Thank you so much. Allow me acknowledge our colleagues in the maternity, KNH, for the good work that they are doing with the tool. And also our Director Nursing Services, Riley Mkwana, Senior Principal Nursing Officer, that is Viola Kiturgo. Nursing Standards also have given us this platform to bring up these particular guides on how far we are and where we intend to be. Thank you so much, everyone.
Thank you so much and congratulations. Looking forward to the next week nursing series session. We'll give you the topic. Have a good afternoon.
Thank you.
And to 621 nurses, midwife and other colleagues, congratulations.